So, hello. So, what I wanted to talk about with you all today is essentially dispelling a common myth that the insurance industry says about Medicare Advantage. And I know James touched on this, but frankly, the recording that he had was from about a year and a half ago. And there's been a lot more information and stuff since then. So this is a significantly expanded and updated set of things from what he how he presented it. But the bottom line is essentially what I believe said, which is that Medicare Advantage hurts people. The insurance industry claims that Medicare Advantage is a solution to equity, but how can a solution to equity be something that hurts people? It just makes no sense to me or to anybody that I know. So, okay, so let's get to that discussion. And then, depending on how time goes, depending on how much Q&A that we have, want to get through kind of running through this a bit, then if there's adequate time, I want to spend a few more minutes putting a context around this because Medicare Advantage is not the first thing our country has done that I believe is harmful, specifically on a racial basis. So I want to put this in a context. It's not just about insurance, it's about a broader problem. But let's get to this. So you'll hear quite frequently from the insurance industry that Medicare Advantage is, of course, a solution to equity problems because people of color choose it more often than do their white co-citizens. If that's, I don't know what the word for that is. It's more often chosen. And so that means that it's a solution to equity. And indeed, that data point is true. Most current data shows that 63% of blacks in Medicare are in Medicare Advantage compared to the overall penetration of Medicare Advantage of 54%. But the question, of course, is does that mean that it's a solution to the racial injustices and inequities in our country? And I think a pretty good um, way to think about that is to think about other ways that other industries that have claimed that wider adoption amongst blacks is proof that they're a solution to equity problems. So, if you think about it, subprime mortgages back in 2006 were much more heavily adopted by black Americans than by most other groups, and certainly more than by whites. And the same thing is true for payday loans more currently. I don't have any more recent data than that, but blacks are more likely to take advantage of payday loans. I don't know if you're familiar with that problem, but payday loans are loans that are outrageously usurious rates. In Missouri, there's something like 3,000% interest. Just crazy rates. And yet, many under-resourced communities don't have banks in their community. And so if you want to get a loan, you have no choice but the payday loan hawks that have moved in. So these are both examples of things that you would not begin to say are solutions to equity, and yet the argument is that they're more widely adopted. So that just kind of is a context that makes it make no sense. It is true, however, when the insurance industry says that blacks are more likely to enroll in Medicare Advantage. And when you look at which specific Medicare Advantage companies or insurance products blacks are more likely to pick, they do it based on premiums. It's the premium that is more likely to attract blacks in our country. So they're much more likely than whites to pick the Medicare Advantage that has the lowest premium available, and they aren't really warned about the hidden consequences. So those lower premium plans, they're also winding up picking plans that have lower quality ratings, and the star rating is a way CMS measures quality. So blacks are more likely to be in lower quality plans. Star ratings are far from a perfect measure of quality, but it's what we have, and so that's an issue. And they're also inadvertently they're picking lower premium plans, but they're picking plans that have higher out-of-pocket maximums. So that's the issue with Medicare Advantage is that traditional Medicare has this 20% co-insurance for outpatient care. I believe I talked about that with you last time, and about a $1,600 maximum or deductible for a hospitalization, up to 3 hospitalizations per year that you have to pay that. And so almost everybody 90% of people in traditional Medicare purchase Medigap, and you can't purchase Medigap if you go into Medicare Advantage, but Medicare Advantage plans have out-of-pocket maximums. And yet, when you pick the plans that have the lowest monthly premium, you wind up exposing yourself to a higher out-of-pocket maximum, which means that you're getting less protection against financial disaster if you go into one of these plans. Again, not a solution to equity. And it's not because they want this, it's because it's the only affordable choice. Those lower premiums are irresistible, and they have no real choice. People that have more financial resources basically reject the plans that have lower quality ratings and tend to reject the plans that have the higher out-of-pocket maximums. So it's again not a solution to equity. And in fact, people of minorities tend to be steered towards lower quality MA plans, such that they're really only offered in these communities. This is an area of study for PNHP. We have a grant where we're studying the impact of Medicare Advantage on equity, and we've just begun a sub-grant of that grant to researchers at Johns Hopkins to look at the differences in plans that are offered in white versus black dominant communities. But the current literature so far shows that they're just not offered the same menu of plans. So they're being steered towards lower quality plans, and they're being attracted by this promise of extra benefits. So I think we all know people who chose to go into Medicare Advantage because of ads like this. You see them all over the TV machines. Join Medicare. Are you missing the benefits that you could be getting through Medicare if you signed up for our Medicare Advantage plan? And they offer a range of benefits. Medicare Advantage corporations offer a range of benefits that are not offered in traditional Medicare, dentistry being one of the most commonly chosen ones. So how good are those extra benefits? Those extra benefits are called supplemental benefits. How good are they? So if you look at what's the average spend for people in traditional Medicare versus in Medicare Advantage, it turns out the value of the Medicare Advantage plan, if you look at total spend, is about $23 per dental visit. So they don't say that on TV. They say, come get a dental benefit. And if you look at what people spend in total on dentistry in Medicare Advantage versus traditional Medicare, the people in Medicare Advantage who have this pharmacy benefit, they have the pharmacy benefit that's not in traditional Medicare, it's pretty modest. So how can this be? How can it be that people that have an insurance product that covers some dental benefit are only getting this little bit? And that's because the devil's in the details, and they don't really tell you all this. So first of all, Medicare Advantage dental benefits are very limited. They typically have even more restrictive networks than Medicare Advantage for physicians. So that means that if you have this insurance, but there's no dentist within 100 miles, you can drive 100 miles or 200 miles to get to a dentist, or as the evidence shows us, more likely, despite having the Medicare Advantage benefit of dentistry, you'll look at it and go, well, I'm just going to have to pay out of pocket. So that's very common to pay out of pocket in Medicare Advantage for dentistry, even if you have this benefit. The Medicare Advantage benefit for dentistry, the majority of them stop at about $1,000 a year. Some go as high as $4,000, but more than half stop paying at $1,000 a year. If you need to have endodontia or root canal or anything fairly the kind of reasons that you want to have dental insurance for, that's well more than $1,000. And most of them, the majority of them, have a maximum benefit of $1,000. Again, pay out of pocket, again, limiting the value to just $23 on average. They also typically, other than for tooth cleaning, require you to pay 50% coinsurance. And you all know what coinsurance is now as compared to a copay. So they require you to pay that. And then they have the stuff that you don't see, in the rest of insurance. They have waiting periods for pre-existing conditions. They have a widely variant list of what they'll cover and what they won't cover. They have a two-tooth maximum policy. Some of them do. It's crazy stuff. So they don't say any of this on TV. But at the end of the day, the dental benefit that attracts so many people into Medicare Advantage is pretty limited. And if you look at, like I said, the total out of pocket that people spend, it's It's not very much less than what you spend if you don't even have a dental benefit. And it's not just dentistry. A very similar pattern is true for eyeglasses, for all the same kinds of reasons. Similar thing for hearing aids, similar thing for durable medical equipment, similar patterns for a whole host of things that attract people but don't really have the value that they promise that they allude to on television. Um, so I don't know if you've seen this, but PNHP, James talked about PNHP's first report on Medicare Advantage, which was the financial piece, because that's how we entered this, right? We thought we had this concern about Medicare Advantage, and we wanted to see when we start talking about the problems with Medicare Advantage, are we talking about changing a program in a way that would save the country money, or changing a program in a way that would actually be expensive for the country? So the first report we did that James walked you through showed that actually there's up to maybe $140 billion that we're spending on Medicare Advantage that we don't spend if those same people were instead enrolled in traditional Medicare and not in Medicare Advantage. So that was our first report about 2 years ago or so. Then last year we said, well, we are physicians for a national health program. We're not economists for a national health program. So we should look at what the harm is. And we did this second report that hopefully you've had a chance to see, looking at the widespread harm. And there's a whole menu of things that Medicare Advantage does that are actually quite harmful to people. And what I'm going to show you is that these harms are in many ways more egregious amongst African Americans. But at a minimum, if it's a program that creates this harm for blacks and whites, it's hard to see that it's a solution to disparities in healthcare. So I think he showed you this slide, which shows that almost all things that you would want from Medicare Advantage require their prior approval. And this is not the complete list. This is just as small a font as I thought you could make and have people be able to read it. So they require prior approval for all kinds of things. What he didn't show you, because this is newer information, is that this problem has been getting worse. So over the last 4 years, Medicare Advantage companies went from, well, when he did his talk of 36 million to now 50 million prior authorizations in Medicare Advantage. That's on average almost two prior authorizations per person every year in Medicare Advantage. Two per year. So that's an average, right? That's the total of Medicare Advantage prior authorizations divided by the total membership. So some people don't have any, um, and some people have 10 or 12, and the prior authorizations often have to be repeated. Sometimes people that are in nursing homes or getting rehab will have to prior approve their rehab, and then we'll have to re-prior approve their rehab 3 days later. So this is a nightmare of problems. What you need to understand is that this is unique to Medicare Advantage. Traditional Medicare almost never requires prior approval. So literally almost two per year per person in MA, and literally one prior authorization per 100 people per year in traditional Medicare. And the ones in traditional Medicare are for the things that probably it's appropriate for them to do. So so there's a big difference between Medicare Advantage and traditional Medicare in terms of prior authorizations. And there's more strikingly a difference whether you're black or white. So the odds that you will have a claim denied by Medicare Advantage are significantly higher for blacks than they are for whites. I believe that's largely related to which plans are offered to blacks versus whites, and it's got to do with blacks choosing the lower premium plans in general, the lower star plans, and that kind of stuff. I don't believe there's any evidence that I've seen that shows that within a plan they segregate out blacks for more denials. That's not the point. It's more the point that blacks, because of the plans that they wind up in, for the reasons we just alluded, are more likely to be exposed to these denials of claims as well as prior authorizations. And then, again, new information, blacks are more likely to not be able to see black physicians if they're in Medicare Advantage. So we know that Medicare Advantage companies have narrow networks. I believe James talked about that, so that they tell you which doctors you can and can't see. The odds that a white physician is in your community, is in your Medicare Advantage plan in your community, is about half. If you want to see a black physician, it's more difficult. First of all, there are fewer black physicians, but second of all, black physicians are less likely to be in your network. How important is that? Turns out that's like really important. Turns out that if you that people like to see physicians who remind them of themselves, for whom they feel comfortable with, for who have more similar lived experiences. And this shows up in terms of clinical outcomes. So if a black person sees a black physician, they're more likely to get this whole range of things, which of course does not mean that blacks should only go to black doctors. Sadly, that's part of what I'm going to talk about in the next segment. But if you want to, for crying out loud, you should be able to. And Medicare Advantage companies actually impede that and make this problem worse. And at the end of the day, minorities, and this study was rolled up minorities. It wasn't specific to blacks, but at the end of the day, minorities will get less health care than do white enrollees. They're less likely to visit a primary care physician in Medicare Advantage. They're significantly less likely to be seen by a specialist, less likely to get a flu vaccine, less likely to get a pneumonia vaccine. They are a tiny bit more likely to get colon cancer screening for reasons I'm not entirely sure of, but for the most part, minorities get less health care in Medicare Advantage than do their white peers. And this means that they have worse clinical outcomes in a whole range of things, which I'm not going to read to you. But compared to average Medicare Advantage enrollees, there's evidence on this CMS website showing that they have worse outcomes on all of these metrics. Um, so I don't know how long CMS will leave this data up, but it is up there today or yesterday when I pulled it for you. Blacks are more likely to be rehospitalized after surgery in general, and that's for all the kinds of reasons of, disparities in care around the country. Blacks typically perform worse than whites on all sorts of public health measures. And here's just one. Even in traditional Medicare, the 30-day readmission rate after surgery for blacks is significantly higher than for whites for all kinds of really dreadful reasons that are in our country. So you would think if Medicare Advantage were mitigating the inequities that we're focused on for this talk, you would think that this gap would narrow. So first of all, whites in Medicare Advantage are less likely to be readmitted after surgery than if they're in Medicare Advantage than they are if they're in traditional Medicare. And it's probably because it's a healthier population in general in Medicare Advantage. It's probably not because of who knows? But the truth is that they are less likely to be readmitted. So you would hope to see the same pattern. You would hope to see an improvement in the 30-day readmission rate for blacks in Medicare Advantage, or at least a narrowing of this gap. But instead, it's worse. So again, does Medicare Advantage reduce inequities and disparities in healthcare as the insurance industry claims? No, it really does not. And if you're we know that black folks have more trouble accessing healthcare because of cost. And indeed, in traditional Medicare, egregious numbers. In traditional Medicare, blacks are twice as likely to say that they have trouble accessing healthcare due to cost. In Medicare Advantage, whites have more trouble accessing healthcare because of cost. Turns out that the ratio stays the same. Blacks are twice as likely to report difficulty accessing care because of cost if they're in Medicare Advantage than whites are. So again, not a solution to equity. And this is even more striking for people who are in fair or poor health, where terrible numbers in traditional Medicare, people in fair or poor health, roughly 1 in 4 people in traditional Medicare of fair and poor health report that they have difficulty accessing care because of the cost of care. Pretty narrow difference between whites and blacks on that metric for traditional Medicare. So it's dreadful, but it does sort of equalize it. How is it for Medicare Advantage? It's worse for whites in Medicare Advantage of fair and poor health, but it's way worse for African Americans who self-describe as being in fair or poor health. 50% of African Americans who are in fair or poor health report difficulties accessing healthcare because of cost. And yet, the insurance industry has the audacious nerve to say that they're a solution to equity. And this is kind of why I'm so focused on this. It's just makes me upset that they would make this claim. So Medicare Advantage basically fails people the most when they need it the most. So how does this work out? So Medicare Advantage lures people in with low premiums and these really modest extra benefits. And as a result, then they limit your choice of physicians. They introduce more barriers to care. And as I showed you, they actually weaken the financial security that it provides. And it perpetuates the racial inequities, and in many ways, it makes it worse. We are feverishly studying this. What I've just shown you is a sample of what's going to be in our report that we're going to produce, that we're going to release in September, and I think you'll get quite a bit out of that. Before I go to the sort of the context, the broader piece of this, I wanted to stop and see. That was a lot of information, and I hope it was a very upsetting and disturbing information. But tell me, don't be shy. Don't prove Betty was right. Yes, Therese. Is it Therese? Teresa? Is it? How do you pronounce it?
Yeah, either one. It's fine. Um,
Okay.
I'm sorry if this was covered already, but I was wondering, how do like racial disparities compare before and after being put on Medicare? Is it about the same or is there any difference?
I'm thinking of the answer, and I don't know that I have a data-based answer for you. That's a really good question. It's a really good question. I've shown you data comparing people in traditional Medicare versus in Medicare Advantage, but you're asking, I think, a really good question. Are both of those problems better or worse than they are pre-Medicare age? And I don't have the answer to that. And if I can remember that question, I'll try to dig into it and bring it back to you. Are any of you familiar with the answer to that? It's a great question. I've got to think it's better because under uninsurance and underinsurance is more rampant under age 65. And I know that blacks are more likely to be uninsured and underinsured. And when you're in traditional Medicare, your insurance is pretty comparable. And people in Medicare Advantage have not the same, but I gotta think I'm speculating and I'm making up this answer, which is not a smart thing to do, especially since you're recording this. But my speculation would be that it's not as bad as it is, but I don't know the answer to that. It's a great question. Thanks for asking that. And it belongs in our report, actually. Yes, and Ani.
Um, so if we did move to a single payer system, what what can we learn from the racial disparities in Medicare Advantage? Like how can that guide a proper equitable design of single payer healthcare?
That's a great question. That's two in a row. Good questions. So
Mhm.
I think the message is the current disparities are made worse because of the difference in the insurance that's being offered. So I mean, a single payer, this would disappear. And actually, I'm going to get to that. I'm going to show you some data about that in a moment. I hate to take my own thunder, but that's at the end of my next section that we'll talk about. That I think there's good evidence that a single payer system would really mitigate, if not eliminate, and maybe reverse some of the inequities. That is like my last slide, I think, I think that is my last slide in the next section. So let me put a pin in that. Zachary.
My question is just about one of the slides. For the out-of-pocket cost for like the supplemental dental and vision, what was the comparison bar for traditional Medicare? Because I know Medicare doesn't offer a plan. I was under the impression you buy like a private plan. So is that
Yeah. So let me call that up if I could. There it is. So this, right? So the comparison there is everybody in traditional Medicare, and I did dig into that question a little bit on my own, and the vast majority of those people do not have a dental benefit. Some do. Some right, and traditional Medicare does not cover a dental benefit, so you're right. They're not getting it through that. But the vast majority of those folks don't have a dental benefit. This particular study didn't address that, but I did look it up elsewhere. So the comparison here is the entire book of traditional Medicare.
Okay, cool. So it's not like a specific population, it's just on average, that's what their out-of-pocket costs. If you're
Correct.
on average. Cool.
Right.
Thank you.
Some of them have a dental, very few, but I forget the percentage, but some of them have a dental benefit, but most of them don't, which is really striking. That means that compared to people who largely don't have a dental benefit, there's a pretty trivial advantage to Medicare Advantage. What else? Yeah, Ariana.
Hello. I apologize if this isn't a great question, but I was just wondering if we're seeing like high percentages of other like racial like minorities also enrolling in the Medicare Advantage plan, since your talk mostly focused on like Black populations, but I was wondering about like Hispanic or like Muslim populations.
Yeah, I mean, it's a challenge to know how much to include in this. So I focused on one. Um, the Hispanic population that has very similar metrics, but better on some and worse, better on some of the measures I showed you and worse on some of the others. So their adoption of Medicare Advantage is higher than whites, and I think it's lower than black. And the outcome differences are better on some metrics and worse on others. So um, um, so it's a good question, and I haven't seen any data looking at Muslim populations. I haven't seen that addressed anywhere. That's an interesting question. Um, and then most other groups that you would want to see the numbers start to get too small to make the same kind of comparisons. But there are numbers on Latinx folks, and it's a mixed bag, but generally worse than whites and mixed compared to blacks. Is that what you were asking? Should I put that data in this next time I show this? I mean, I pulled it out because it just gets to be too many bars on my charts. But did it feel like that was an exclusion that I should? I don't know. It was actually in an earlier version of this set of slides from about a month or two ago, and I pulled it out because it's complex. But I'll rethink that. Thanks. Natalia.
So kind of a similar question or related. I was wondering if you've stratified by income, or I know a lot of people aren't working, so maybe net worth or something like that. Since you did mention that a lot of people are perhaps choosing these plans because they're cheaper on first glance.
Yeah, so absolutely lower income folks are much more likely to do this. And we know that the net worth of blacks tends to be, for all the obvious reasons, is lower than it is for whites. So that confounds it. But when you control for that, it's still very similar because it's still a problem because they're marketing it to majority black community. They're marketing their worst plans to majority black communities. One of the things in our study that we're going to be doing that we'll release this September is actually focus groups in two African American communities in Baltimore. One in Baltimore City, where it's a lower income black community, and then we're also going to be doing a focus group in Prince George's County, I think is the name of the county. It's one of the wealthiest African American communities in the country. So we're going to be doing a focus group trying to answer that question as much as we can. And some of the quantitative analysis we're going to do is going to try to get to that too. But it's still, at this point, I would say the data suggests it's still a major issue, even if you control for wealth and income.
Um, I had a question that I just thought of, and if this was covered in your talk already, I'm sorry, but we've heard a couple times that lobbying groups use the fact that Medicare Advantage is more equitable as a reason for why it should be funded. What data are they using
So
to support that?
two arguments that they make for that. The first is that indeed the adoption by blacks is higher than the adoption by whites.
Mm,
And there are these extra benefits as I said, they're much more limited than people like to think, but there are these extra benefits. And so, Congress is afraid to touch Medicare Advantage. Every time we've gone to Congress, we went to Congress before we did our first report. We went to Congress after our report about the finances. And both of those times they said, but the African American community loves Medicare Advantage. Look at the penetration, they love it. So then we went back and did what we thought was the final answer, which is, but look at the harm that it's causing. We'd say, it's hurting people. It can't be a solution. And Congress didn't, that was like, didn't mean anything to members of Congress, most of them, because they said, well, but, that's not what we're hearing. We're hearing that, look at the penetration. Fuck, so the penetration is a big deal, and that's why we're doing this third report about the specific impact of Medicare Advantage on equity. But there's another argument that the insurance industry makes, and that is they have about a dozen studies that purport to show better outcomes for Blacks in Medicare Advantage than for Blacks in traditional Medicare. So we've looked at those because, if that were true, well, then, I would rethink my whole logic here. And two things about that. The first is that every one of those studies is adjusted for the Charleston Comorbidity Index, if you know what that is. They're adjusted for the acuity. So how do they adjust for the acuity? That means that, if it's a sicker population, they adjust the data for that, the outcomes data. Well, I think James made the point that the data, the acuity, the data about people in Medicare Advantage captures a lot more diagnoses than it does in traditional Medicare, because Medicare Advantage companies are paid more. Their capitation rate, their benchmark is higher, is adjusted up based on how many extra diagnoses they can pile in. They have a financial motive to add diagnoses in Medicare Advantage, and that motive doesn't exist in traditional Medicare. So traditional Medicare, the coding by we docs, is limited to the things that are clinically important to us taking care of the patient. In Medicare Advantage, there's a whole suite of things to capture extra diagnoses. There's machine learning tools, there's AI algorithms, there's home visits from nurses that do just one visit, not a series of visits, just one visit to capture more diagnoses. They do all kinds of things to capture more diagnoses. So in Medicare Advantage, it looks like a sicker population based on coding. So when you adjust the outcomes data based on the coding that's captured by Medicare Advantage, it looks like, they've gotten superior outcomes because, but that's ridiculous and it's not true at all. And so when you really look at it, no, it's not true. But they have tomes that they can slap on members of Congress's desks saying, look at this evidence. It's better outcomes for Blacks in Medicare Advantage than in traditional Medicare. Every one of those studies that we've looked at has been incredibly bogus and crummy. But that's their second argument, is that it's actually helping people. Takes kind of a sophisticated answer to dig through that and to dispel it. But that's the kind of thing. I was hoping that our grant, we were hoping that our study was going to be actually looking at the differential in long-term outcomes for Blacks in Medicare Advantage versus in traditional Medicare. And that turns out to be a much bigger study than we have the time or grant scope to do. So we'll see how when this report comes out in September, and I don't think anybody's done that. I don't think there is a robust answer to the question of how are outcomes different, other than the crummy stuff that the industry produces. I was hoping we were going to be able to produce that, but we'll see how this first report we're producing in September lands. And then on our list of things we might want to get a subsequent grant for is that study. So that data doesn't exist yet. So I'd love to be able to dispel it with something more than discrediting their methodology, but we don't have that on a numerical basis yet. Those are the two main arguments I've seen them using. These are great questions. What else? Caitlin. Nope,
Hi.
Caitlin's not. Oh, there you are.
Oh, yes, thank you. Yeah, oh, sorry, I was frozen. I had a question regarding something that we talked about a little this morning with Dr. Malik about Medicare Advantage regarding one of the readings that I think it's an opinion piece by Dr. Malik, where it mentions that Medicare Advantage is constantly being promoted on TV ads and such, like by, I guess, celebrities like Joe Namath, which I didn't know who he is, but I guess he's a New York Jets quarterback. But so yeah, I mean, I think it's really interesting that like people brought up this morning that the downsides are not really publicly available or just publicly known to Medicare Advantage, like the payment denials and all the data and the prior authorizations, but it's just so prevalent, I guess, with advertising, but it's misleading. So I'm just wondering if you have thoughts on that or how to regulate that kind of misinformation or misleading advertising.
Yeah, that's a big deal.